Hawk, Hicks of Hawkins, Hicks of Washington, Frith, Love, Lynn, McKenzie, Miller, Moon, Parkinson, Shaw, Sparks, Whitson, Williams, Zachary, Vice Chairman Baum, Chair Lady Hazelwood.
Here.
Madam Chair, you have a quorum.
Thank you, Mr. Clerk. I hope everybody had a good long weekend and we're back and ready to go. Before we get started today, are there any personal orders or announcements? Seeing none, we have 2 budget hearings scheduled today, but we do have 3 bills on our calendar. And in deference to those members who have other places to be and are presenting bills, we'll take up those bills first. So, and members, as always, you can refer to your dashboard. Any presentation that's on the screen will be on your dashboard as well. But the first item on our bill calendar today is House Bill 1021 by Chairman Doggett.
Motion. Second.
You have a motion and a second. Chairman Doggett, you're recognized.
Well, good afternoon, Chair Lady and Committee. Thank y'all. For today, we do have an amendment. It's coded 13327.
I believe that amendment's traveling with it, Chairman Doggett.
And thank you, ma'am. And you would think I would know that, but it's a rarity that I make it this far into finance. And so I'm still learning. I want to say a thank you again to the Treasurer's Office, Treasurer Lillard, the District Attorney General's Conference for their help on this. This deals with the Victims' Compensation, Criminal Injuries Compensation Fund. We've made some changes to how this works, and so we find ourselves, I think, with this legislation in a very good place. It's going to help victims of violent crime, those especially those that are survivors, some of the things that they may need to help make them feel whole or get them on the right path.
With that, do I have any questions? I will note for the records, we do have a funding letter for this bill. So are there questions for the sponsor? Question has been called. Without objection, we're voting on House Bill 1021. All in favor, please signify by saying aye.
Aye.
Any opposed? The ayes have it. House Bill 1021 moves on to calendar and rules.
Thank you so much.
Thank you. Item number 2 on our calendar is House Bill 1693 by Chairman Boyd.
Second.
We have a motion and second. Chairman Boyd, you're recognized on House Bill 1693.
Thank you, Madam Chair Lady. Members, House Bill 1693 amends the statute as it pertains to Tennessee's Commission for the United States Semi-Quincentennial Commission Act. And so in 2019, in preparation for our country's 250th birthday, we put together a commission. And this simply makes a couple of changes that allows the members of the committee to send a designee or a proxy to commission meetings, and it transfers responsibility from Department of Tourism over to the State Museum. Madam Chair Lady, I'll take any questions.
You've heard the sponsor's explanation. Are there any questions? Seeing no questions, we are voting on House Bill 1693. All in favor, please signify by saying aye.
Aye.
Any opposed? The ayes have it. House Bill 1693 also moves on to calendar and rules. Third and last item on our bill calendar is House Bill 1651 by Chairman Whitson.
Motion.
We have a motion and a second. Chairman Whitson, you're recognized.
Thank you, Chair Lady, and I've requested present from my desk. Members, Chair Lady, I have amendment number 13744.
I have a motion and a second on the amendment. Any objections to the amendment? Seeing none. Amendment 13744 is hereby attached to the bill. Chairman Whitson, if you would share with us what the bill does as amended.
Yes, ma'am. This legislation will temporarily open the application window to allow community organizations the opportunity to have their charitable events applications reviewed and considered for approval by the Secretary of State. With that, Madam Chairman, I renew my motion.
Are there questions of the sponsor? Representative Parkinson.
Thank you, Madam Chair Lady, and thank you, Mr. Sponsor. I have no idea what we're doing here. Is there a reason why we're opening, why the window's not open, or?
Chairman
Yes. Hey,
Whitson.
good question. Some organizations like St. Jude's and My Rotary did not get their application for charitable events in time. This opens the window so the Secretary of State can consider those applications.
Thank you, sir.
Further questions for the sponsor? Seeing none. We're voting on House Bill 1651. All those in favor, please signify by saying aye. Any opposed? The ayes have it. House Bill 1651 moves on to calendar and rules. That brings us to the end of our bill calendar today. Without objection, we are out of session, and we are going to ask Director Smith if he would come forward, as TennCare is our first presenter for the afternoon. Welcome, Director and team.
Thank you very much, Madam Chair Lady, members of the committee. It's good to be with you all this afternoon. My name is Stephen Smith. I serve as the TennCare Director. To my right is Zane Seals, our Chief Financial Officer. And to my left, we have Kim Hagan, our Director of Member Services, and Dr. Victor Wu, our Chief Medical Officer. I know we are limited on time, so we're going to jump right in. Our mission at TennCare is to improve lives and to do that through high quality, cost-effective care. And I'm really proud to be able to say that due to the hard work of many people over many years, TennCare is stronger and more successful today than at any point in its history. Whether that is measured by that cost-effective piece of our mission or whether that is measured by the quality piece. Our purpose here today with our budget presentation, of course, is to talk about the present and the future of TennCare. But in order to do that, I want to spend just a little bit of time talking about the past, because the past plays such an important role in the decisions that we still make today. In your slide deck, you will see a graph that represents that past. That serves as a warning to us today, but it also serves as a resource. What you see in this graph is a trajectory in the early 2000s where TennCare was set to capture every available new state revenue dollar in just a few short years. As we have discussed many times, that simply was not an option. And so our state took the first steps then to right the ship and to put us on a path that has led us to the enviable position that we find ourselves in today. That took considerable work and strong leadership from many people over 2 decades, multiple governors, multiple committees, multiple members of the General Assembly, multiple administration staff, our partners, our MCO partners, our providers, who learned from the mistakes of the past and committed to moving forward with responsible, efficient, and innovative management. Mistakes that again led to the TennCare budget taking everything to one where the state can make record investments in public education and at the same time make record investments in TennCare, which is exactly what has happened over the last few years. This concept of efficiency and reinvestment is exactly what our latest innovation in TennCare, known as TennCare 3, and born from a partnership with the General Assembly, is all about. It actually takes that concept and it accelerates it by rewarding Tennessee for our effective Medicaid management, and we do that through the form of shared savings. That means that those savings stay here in Tennessee rather than revert to Washington, and then we take those savings and we reinvest them back into the TennCare program. Since the inception of this waiver, we have had the largest TennCare investments than anyone can remember, highlighted by the items that you see here on the screen, and inclusive of more than $2 billion in provider investments. That's in addition to the negotiated rate increases through our managed care operations. All of these investments are made possible by our confidence to be successful under the provisions of TennCare 3. And now we have confirmation that not only is TennCare 3 working, it is a resounding success. Last year, Governor Lee announced a first-year shared savings of more than $300 million that we, with the approval of the General Assembly, are doing exactly what we said we were going to do: enhance benefits, and yes, expand coverage to more people in need. 25,000 additional children, pregnant women, and parents through the Strong Families Initiative. As we look forward to FY25, I'm really pleased to be able to share with you all that we have another $300 million in shared savings for year 2 to further our priorities in health and healthcare. That's more than $600 million in just the first 2 years of this 10-year waiver. Our proposal for this second year of savings reflects a 5-year plan that will extend these funds through FY29 and focus on 2 key areas of incredible importance: rural health and behavioral health. We are proposing a $200 million investment in rural health with $80 million allocated for FY25. These funds will focus in two areas. First, as the governor announced in his State of the State address, we will fund recommendations from the governor's Rural Health Task Force. And these investments will target access and workforce development. And then second, we will fund an additional round of a very popular healthcare resiliency grant program, which will target our rural providers. This $200 million investment will actually be implemented by other departments. I know we have the Department of Health that follows us, and many or most of the provisions in the Rural Health Initiative will be implemented by that department. So we will defer to them for specifics, but we are really excited about these investments, and we're confident in their ability to positively impact the TennCare members that we serve. Next, we are proposing a $100 million investment in behavioral health with $40 million allocated for FY25. We know that behavioral health continues to be a major priority for both you and for us. And so we're very happy for the opportunity to have these shared savings and to bring this plan to you. These funds are targeted to community mental health centers, other substance use disorder providers, behavioral health hospitals, children's hospitals, primary care, and others. The key point here is that we are targeting areas where we see a specific TennCare need, very complex cases where access, workforce, and expertise are needed. These investments, again, are made possible by TennCare 3 and the resulting shared savings. I think they confirm the collective sound decision-making of our state regarding our Medicaid program over the course of the last 2 decades. One of the primary and unique benefits of shared savings is that we can do all of these things at no additional cost to the Tennessee taxpayer. It's a remarkable accomplishment, but it's one that is only possible, again, because of the decisions and the work of the past. At the end of the day, it's about improving health, which drives down healthcare costs, which results in shared savings, which results in reinvestment of those savings back into our program to improve health. And so it's a cycle, and the cycle starts all over again. Moving to slide 6, I want to quickly go over a couple of other proposed items. Like last year, we are seeing continued impacts of inflationary pressures on our general costs of medical care. Item 14 represents Medicaid trend. That totals $200 million in state and federal dollars combined. To give you some better context here on the impact of inflation, if our current medical utilization had rebounded back to pre-COVID levels, coupled with the inflationary impact, this item alone would be approaching $500 million. Second, I'll point to Medicare services, item 15. This is $85 million. It specifically relates to Part D, which is the pharmacy benefit for people that have Medicare. We have no control over this. We simply get a bill from the federal government, and this relates, again, to people that have both Medicaid and Medicare. And then I want to highlight some provider investments. First, you'll see item 12, which is a recurring hospital investment totaling $35 million. This addresses a portion of the hospital assessment. It's buying back a proposed cut from 2010 that relates to Medicare Part A reimbursement. Second, item 13, we have a year 2 of a 2-year commitment for nursing facilities at roughly $50 million. And then third, item 30 on slide 4, we have another year of increases for direct service professionals in our home and community-based service programs. So this targets the average hourly salary at $15.25 versus the current $15 per hour. We have several other items that are listed here. We're happy to talk about those, but in the interest of time, I'll close with some encouraging news. As many of you know, we have a survey that's conducted every year by the University of Tennessee, and it gauges Tennesseans' satisfaction with their health insurance plans in an effort to gauge satisfaction with TennCare. This year, we're happy to report we have a record satisfaction level of 95%. And for the first time in the survey's history, reported quality of care for TennCare households and their children met or exceeded the reported quality of care for all Tennessee households, which includes commercial private plans. So that's something that we're very proud of. That's no way to suggest that we can't or should not improve. Certainly we can and we will. But when we talk about our success, I can think of no better measure than our members' own opinions. That completes my prepared remarks. Madam Chair Lady, we're happy to stand for your questions or comments.
Thank you. There's a lot, obviously, TennCare is a huge part of the state budget, and there's a lot here to digest and a lot of things that obviously you didn't have time to go into. But we do have a series of questions, and beginning with Chairman Hicks of Hawkins.
Thank you, Chair Lady and Director Smith. It's good to see you and your team here. And I'm going to focus on shared savings. I know sitting through Insurance Committee a little bit earlier today, and we talked about that. So I guess I'm going to get a double dose of it today. So the budget, as you just proposed, and if you look in there, there's multiple proposed cost increases really across several agencies utilizing shared savings. So uses for the shared savings include, and this is just some of the things that the shared savings is going to be used for: the creation of pathways for people to enter into healthcare careers through THEC, competitive grants for capital investments to expand capacity, and apprenticeship opportunities through the Department of Labor. So that's just a little bit of context to kind of set the stage for the questions that I have. So my first question is, did TennCare receive guidance or approval from CMS to use the shared savings on these initiatives?
So the commitment to CMS, as well as the governor's commitment, was that we would use these dollars in a way that would improve the TennCare program, or would be utilized in a way that would benefit the TennCare members that we serve. So we do not have to submit each specific proposal to CMS as long as they fit within the guidelines of those broad requirements. So we're very confident that everything that's proposed in the year 2 shared plan would positively impact the members that we serve.
So with all due respect, that's what we heard from the Department of Education as well as DHS regarding the TANF funds. And yet here we are having to pay that back. So I would just urge you to make sure and double check, because we don't want to be in the same position with the shared savings that we find ourselves in with education and with TANF funds.
Yeah.
But moving on, so the majority of the programs are projected to have shared saving obligations for 5 or more years. So with that being said, will TennCare be tracking outcomes for all the programs which are going to be paid for out of the shared savings?
Thank you for the question. So we've been very careful to ensure that there will be no fiscal cliff with these shared savings funds. So you'll remember with year 1 shared savings, we actually have some improved benefits, and we've actually brought some more people on through the Strong Families Initiative. But remember, with the year 1, we put in, and you all approved, recurring dollars for those provisions, and then the shared savings actually buys back those recurring dollars all the way through 2030. The year 2 shared savings proposal is different in that these are not recurring expenses. This is a 5-year commitment. I guess you could call it a pilot, so that there is no requirement that these continue after FY29. But to your question, we will certainly want to track outcomes and see if the investments have actually resulted in what we think they will result in, which would be improved access, improved workforce.
And then if TennCare notices that these programs are underperforming, is there any steps that TennCare plans on taking for these obligated funds?
Well, so we've committed for the 5 years, but I think certainly after the 5 years, as we're making decisions about future shared savings, and I'm very hopeful that we're going to have more shared savings as we move through this waiver, and we'll bring those proposals to you all, and you all have a great opportunity to invest those dollars. But I'm hopeful that we see great results with these programs, and that we can have a conversation about continuing them. It's probably not realistic to think that we would continue all of them, but I would certainly hope that we would find a good number of them resulted in great success, and we'd want to continue those.
And then I'm almost finished, Madam Chair. The first year shared savings, I've got 331 million. The second year was about 303 million. So what about moving forward? What are you anticipating in the swings? Will we see a more increase? Will we see this increase or decrease?
It's really hard for me to, I can't commit to a number, of course, because it's all really dependent upon other decisions that we make. It's all dependent upon our spending versus our, what's called the budget neutrality cap, which is, it's not as though we get a block of money, but we have a cap, and and our shared savings is based on the amount of dollars that we spend below our cap. So, but I would say there is no reason why, if we continue to do the things that got us here, that's when I was talking about the past and why it's so important to the decisions that we make today. If we continue to do the things that got us here and manage well, and spend responsibly, there's no reason why we can't continue to see significant shared savings opportunities like we've seen these first couple of years.
And then I'll be finished. So what is and this is just something I've been wondering. So what is the correlation between the shared savings and the reversions?
Well, there's really no correlation. The reversion this year was just very, very unusual because we've had these enhanced federal matching dollars during the public health emergency. And that has really resulted in the bulk of the reversion, that large reversion number that you see this year. And that we're no longer getting those enhanced federal matching dollars. So we don't expect that we're going to see these kinds of reversions in the future.
Okay. Director, thank you. Thank you, Madam Chair.
I'd just like to follow up and make sure I understood the answer to one of Chairman Hicks' questions when we were talking about the 5-year pilot programs, if you will. So if I understood you correctly, we are committed to doing those for 5 years, regardless of performance or outcome, even if we see after year 2 or year 3 that one of these programs is not being effective or, just isn't performing or doing what we'd expected it to do, we still are committed for 5 years?
Well, I probably overstated that. I on the front end, we're committing to 5 years, but I mean, and we're gonna have to work very closely with, especially on the rural health stuff, with the other departments that are actually implementing this. We're gonna have to work very closely with them, but certainly if we see that something just isn't working, then we can have a conversation about that, and we can redirect those dollars. I think we just want to be careful because we're going to be making some commitments to some of our providers, perhaps, and they may be making decisions based on those dollars. So we'll want to be very careful about that, but certainly you all have the authority as the funding body to make some different decisions, and we would want to work with you and the other departments that are implementing these to make sure that we feel good about how the dollars are being spent.
And I understand that you are working in tandem and there's a lot of collaborative efforts going on, and you wouldn't want to pull funding from, another organization or entity that had been counting on that. But at the same time, a lot of these initiatives are very new, and we think they are going to work. Otherwise, we wouldn't be doing them. But we really don't have any, evidence to support that. So I would just expect all of us to kind of keep an eye on that. And, if something's not working, then we ought to have the intestinal fortitude to say it's not working and redirect funds in a way, to something that's more positive. Chairman Baum.
Thank you, Madam Chair, and thank you, Director Smith, for being here. My first question has to do with the bed assessment. Periodically, TennCare is required to update the nursing home bed assessment. Maybe it's every 3 years.
Yeah.
And that, my understanding is that has recently been done to be funded, I guess, at the beginning of the next fiscal year. And I guess my question is, when you I say update the bed assessment, it's rebasing the bed assessment. Are you doing that based on actual costs or on some kind of inflation adjustment where you take old costs but just move them up for price inflation?
Yeah, the quick answer to your question is it's based on inflation. But to get into the detail, I think you probably want more detail than that. I'm gonna defer to Zane.
Thank you for the question. Zane Sills, Chief Financial Officer. So we rebase our nursing facility payment system at least once every 3 years. It could be rebased more often than that, but this is the third year, so we will be doing a rebase 7/1 of 24. Last rebase was 7/1/21. And the way that works is we have a metric that is enshrined in rule called the Nursing Facility Market Basket. It is a national inflationary metric that is specific to nursing facilities. So we're not just kind of going out there and grabbing general inflation, for the economy. We're wanting to grab something that's authoritative and used widely around the country, specifically for nursing facilities. So that's the metric that's enshrined. And every year, that is what essentially the nursing facility rates will increase by that nursing facility market basket rate. And so unless there's some sort of budgetary crisis, that would interfere with that. So we are budgeted for and planning for on 7/1/24 to, when we rebase the nursing facility rates, see an increase that's equivalent to that nursing facility market basket inflationary metric.
Okay. Next question. I guess this is more about the hospital assessment. My understanding is that TennCare has a hospital assessment. That money is used to help fund TennCare, but then it also benefits hospitals because it draws down more federal money. Could you give us maybe a brief general overview of how that process works? And then maybe, I guess, include as part of your summary, whether this is adequately funding TennCare and whether it's adequately benefiting our hospitals.
Yeah. Well, the history of the assessment, it dates back to 2010, where at the time the state was going to have to make some difficult budget decisions, and there were multiple cuts to the TennCare program that were proposed. And the hospitals, to their credit, stepped in and said, we will implement an assessment. Essentially, we will pay the state portion of the cuts, and that will allow us to draw down the federal funds, and then that would prevent the state from having to make the cuts. And then over time, there have been additional dollars that have been distributed to hospitals through the assessment. In recent years, as you all know, there have been some discussions about the state buying back those dollars that prevented those 2010 cuts. Last year, there was an investment, a one-time investment taken out of our reserves to, is about $110 million to, I think, account for some of the assessment dollars. And this year, on a recurring basis, that $35 million that I talked about, that is related to one of the items that the hospital assessment bought back from those 2010 cuts, that Medicare Part A reimbursement. So that's $35 million total. That's on a recurring basis, whereas the 110 from last year was non-recurring. So we are we're doing something there. Now, granted, it's not. I don't want to speak for the hospitals, but I'm certain they would want to see more than that. But we're in a challenging budget year, and that's what we felt like we could do this year. I don't know if that answers your question.
I've got a couple more on that, I guess, on that theme. Has the 110 million been dispersed? And maybe if so, how do you decide which hospitals get it?
Well, has it been dispersed?
Right now, it's in the process of going out over the back half of February.
Yeah.
Okay, and then maybe last question, if a larger hospital assessment would allow more federal dollars to be drawn down, is there some reason why, what would be the reason why we wouldn't want to increase the size of the hospital assessment? I assume there's probably some maximum, and if there is, are we at the maximum?
We are not at the maximum. So the maximum is 6%. That's federal. So there is some room. I think we're at about 4.87%. So there is some room. Um, it's, I think there could be differing opinions about whether going up to the max is in the best interest of the state or not. I think there are arguments on both sides of that. It certainly would result in more dollars to hospitals, and it is true that it would be done in a manner that does not impact the dollars that the state has to put in. Conversely, those are still taxpayer dollars that you're drawing down at the federal level. And so depending on the size of the drawdown, I think people may have differing opinions about how much is the right amount.
Okay, and then last question, sort of maybe the prior question rephrased. Who would be hurt if we went to the maximum for the hospital assessment?
I certainly couldn't sit here today and tell you a specific entity that would be hurt. I do think there's a philosophical discussion around how much we would want to draw down, how much we would want to rely on an assessment, how much a Medicaid program should pay. I think those are legitimate philosophical questions. There potentially could be some long-term impacts, some unforeseen impacts. But I wouldn't want to suggest that I could sit here today and tell you, well, X, Y, and Z would be hurt if we go all the way to 6%.
Okay, thank you.
And I would remind members and those watching that when this hospital assessment was instituted, it was to be a temporary stopgap measure. It was never intended to be a permanent situation, although it's looking fairly permanent at this point. And Director, you mentioned the $35 million, 12 million of that, a little over 12 million is state funds. The rest is federal. The $110 million that you mentioned from last year, how much of that was state? How much of that was federal?
That was all state. 110 was all state.
So this last year on a one-time basis, we put in 110 million. This year we're putting in 12 recurring against that buyback. Chairman Whitson.
Thank you, Chair Lady Hazelwood and Director Smith. Good to see you and your team this afternoon. My question has to do with new position requests and vacancies. Proposed budget includes 13 new positions for TennCare. Back in January during the questionnaire, TennCare reported they had 57 vacancies. And as of December 21-22, you had reclassified 104 positions so far. First two questions: why do you need the new positions now? And why can you not reclassify and utilize vacant positions as you've done in the past?
Yeah, thank you for the question. So of those vacant positions, only 5 of those have been vacant longer than 12 months. So we fully intend, we have some natural turnover. Our average turnover rate FY23 is 6%, which is actually pretty low. So we have some natural turnover, but in terms of long-term vacancies, we only have 5 that have been vacant longer than 12 months. The positions that we're requesting, and we fully intend to fill those. There are some positions that are difficult to recruit for because of the, we're doing much better in state employee pay, and I want to thank you all for that because your investment, it really is making a difference. And so we're starting to be able to fill those roles in a way that we haven't been able to in the past. The positions that we're asking for are, of course, new positions. But that would be the reason.
Yes, and that kind of leads into my next question. You talk about pay is getting better. There are other obstacles, got a code, to fill in those long-term positions, the 5 you mentioned, and any others?
I think just the workforce challenges that everyone is experiencing. We have a lot of competition in this market. I think we're doing pretty well. Again, only a 6% turnover rate. I think we could probably put that up against any of our competitors. So I feel good about that. But we have the same challenges that the rest of this market has.
Thank you, Chair Lady.
Chairman Williams.
Thank you, Chair Lady. Good afternoon. Just had a question about ECF choices. I noticed the governor put some money in, I think it was $9.5 million recurring, some federal drawdown dollars in order to continue to chip away at the ECF choices list, which most of the colleagues on this committee don't realize what that used to be. So it's kind of nice to see it below 1,000. But the rest of the question, or the question really is when we look at your questionnaire for leading up to your budget discussion, it said that in order to make that list go away for the 987 people on there, it's the same $19 million. I guess the question is, what happened between the questionnaire and the budget presentation where the same $19 million only serves 300 people, but in the questionnaire it's 980 some odd folks?
Yeah. So thank you for the question. I think I can clarify this. So the dollar amount that you're referencing that's in the budget, that's really different from the waiting list. So these are 300 crisis slots. So these are individuals that we have to serve. So for example, maybe they have an aging caregiver, or there's some other change in the situation, and the situation is so serious that by law we have to serve those. And those are more complex cases and they're more expensive. So those crisis slots are the most expensive slots that we have. We really think about those slots as separate from the waiting list, because there really is no waiting list for these people that are in crisis. We have to serve them immediately. And we typically use the attrition dollars from the DID 1915 waivers to serve the additional crisis slots that we need. So two different pots, but it is confusing. So I certainly understand the question.
So what we have is are we paying for it out of TennCare now, and we weren't paying for it out of TennCare before, and that's why it was in DIDD because they were crisis beds, and is that why? Do we have two lists?
Well, so the way that the 1915 waivers, those are closed. So as people pass away in the DID program, it frees up dollars, and we typically we've used those attrition, those dollars, to be able to serve the additional people that come in a crisis situation. So I think about 300 is the typical number that we anticipate every year in the crisis slots. Last year, I think was the first year we didn't ask for any crisis slots because we had enough money in our budget to cover that. So we didn't have to make an ask. This year we did.
So for the enrollment or the eligibility requirements, give me an example of what's the difference between somebody that's eligible under a crisis and what somebody's eligible under the ECF choices, if they're two different ones.
Yeah. So for the crisis slots, the situation here would be there's no one available to care for them. Their caregiver perhaps is incapacitated, or there's no alternate living arrangement for that individual, an abuse or neglect situation, or that person's at risk of being placed in a nursing facility or an ICF IDD. So these are, or I mentioned before, they have a caregiver that has passed away. So an aging caregiver that can no longer take care of that person.
Okay, final question, Chair Lady. So how long does someone receive services that is in crisis under this new to me, group? Is it limited?
No, I don't. That would not be a temporary service. I think once somebody is in crisis, we're going to be serving that person probably through the rest of that person's life.
Okay, thank you.
Related to that, last year when we were here this time, we talked about the waiting list and the improvement on that, for which we're all grateful. But there also were some issues where they were no longer on the waiting list. They were approved for services, but services were not being made available because of workforce shortages and those sorts of things. So is everybody that is approved for ECF and also on these additional slots for seniors, it says the slots have, they are there, but just because I'm in a slot, does that mean I'm actually getting the services? Or might I still be on a waiting list to get those services from one of our providers?
I wish I could say that every person is getting 100% of the services. I can't say that. We're still experiencing the challenges, not to the same extent as last year. We're doing better. We've had about a 58% increase over last year, but we're still facing the same types of challenges that we're seeing all across the country. So I can't say that in 100% of the cases, those individuals are receiving 100% of the approved services. We're doing much better, but we're not there yet.
Thank you. Again, just to point out to this committee, while we're all excited about the decrease in the wait list, the length of the wait list, but as the director said, we have a lot of work to do to make sure that people are removed from the waiting list, but those who are technically not on the waiting list, remember, there's still not all of those people are being served. So we have a long way to go before we can pat ourselves on the back. Leader Cochran.
Thank you, Chair Lady. Just a quick question on your employer agent. So this fiscal year, TennCare switched employer agents. And then, there was a report in November that people were struggling to find, hire, schedule, and pay in-home caregivers due to the issues resulting, again, from this new fiscal employer agent that we're using. To the best of your knowledge, have those issues been resolved? And then, is TennCare, are we still receiving a lot of complaints about that? If you could just give us an update.
Yeah, appreciate the question. So you're right. We switched vendors and we had some initial hiccups for sure as we transitioned to the new vendor. I can tell you that the complaints have decreased substantially. I feel like we're in a good place. One thing that we did is we established a member advisory council. The Disability Coalition is part of that. So the communication has been a lot better. We're working with the stakeholders. The new vendor has been heavily involved in those discussions. We've asked anyone that's having a continued issue or any stakeholder that is aware of an issue, let us know immediately, and we will work to get on that as soon as possible. So I think we're in a much better place. Hopefully you all are hearing a lot less than you were hearing several months ago. We certainly are. So I think that's a good sign.
Okay, thank you.
Representative McKenzie.
Thank you, Madam Chair, and thank you all for your presentation and the numbers. You spoke earlier on an increasing enrollment in members on TennCare or citizens on TennCare. Could you give me a little more information along the lines with mental health? What general health care, or what and what the numbers look like?
Sure. So we have had a pretty sharp increase in our enrollment. That's due to the public health emergency, and during that time, under federal requirements, we were prohibited from removing anyone from the TennCare rolls. And so at our peak, we reached about 1.78 million. Prior to the pandemic, we were at about 1.4. So that continuous enrollment provision has ended, and so we started renewals back in March, and we are currently down to about 1.6 million. I feel good about where we are as a state in terms of our renewal process. We were extremely well prepared. I think a testament to that is the fact that we're one of only a handful of states that has not had to submit a mitigation plan to the federal government. And we're in a minority of states that has not had to pause renewals at any point during the process. If you look at kind of where we are compared to, I'll give you all, I know I came to this committee maybe last month and gave you an update. I've got some new numbers. They look pretty much the same, but just to kind of give you a better picture of where we are compared to the rest of the country. In terms of the percentage of people that have been renewed, that have gone through the process, we're at 62%. The national average is 51%, so we're higher. When you look at the percentage of people that have been renewed automatically, meaning they haven't had to do anything, we can use other data sources to go ahead and renew them. We're at 42%. The national number is 32%. If you look at the percentage of people that have been removed from the Medicaid rolls, we are at 31%. The national is 26%. So we're a little higher, but I'll point to the pending number. Those applications that are pending, we're at 7%, and the national is 23%. So what that tells you is that a large number of that 23% are ultimately going to be removed. So I think when it's all said and done, we're going to be right there at the national, near the national numbers. So I feel really good about where we are in terms of process. We still have challenges, just like every state in the country does, relative to having every member respond to the request for information. But I feel good about where we are.
Representative McKenzie.
Thank you. Final question. So in terms of Medicaid expansion, what would that do with those? I've got the word you just used, terminated numbers, the ones that were put off. What would that? How would that affect that?
Well, it is true that some of the members that would be removed would be eligible, but I think sometimes there's a perception that every individual that is removed during this process would be eligible if we expanded under the Affordable Care Act, and that's just not the case. If you think about it, the majority of people that we serve are children, and we serve children up to 250% of poverty. The expansion population only goes up to 138% of poverty. Those that would be eligible would be situations where you have a child that has aged out and is now an adult and is below 138% of poverty. You might have a situation where you have a parent of a child that is on the program now. The child has aged out, and so the parent is no longer eligible. So situations like that, but it doesn't mean though that, I think it's important to note that it's not as though every person that is deemed ineligible would be eligible if we expanded.
Representative Barrett. Leader Camper.
Thank you, Madam Chair. Thank you, Commissioner, for being here. Couple of questions. One on page 5 of your presentation. Oh, that's it. The behavioral health hospitals at the top. That $15 million. Is there any stipulations on how those funds should be used or could be used? Could you talk a little bit about that?
So we are designing that as a grant program, and the idea is we would have 10 grants, and they would be for $1.5 million per year for 2 years. We want to, of course, target those to hospitals that are serving TennCare members. And so we will have weights for in the application process or the grant process. We would weight those positively for those that actually are serving a good percentage of TennCare members. But we have to develop all of those details. But those are the basics.
Leader Camper.
Thank you, Madam Chair. Thank you. I'd like to go back to this hospital assessment that we've been doing. If memory serves me correctly, and I think you mentioned 2010, that was after the Great Recession, and there was these proposed recurring budget cuts that was expected during that time to get us through the recession. And so Governor Bredesen at the time accepted this philosophy of drawing down these assessments so that we can get the matching dollars and we can in fact not have these recurring budget cuts that was about to happen during the Great Recession. If I'm not mistaken, Madam Chair, in the budget document, the appropriations bill, there should be some language in there that says if we don't do this assessment, then TennCare would be required to make some cuts. Is that correct, Mr. Commissioner?
Yes, that is correct.
Okay. Secondly, Madam Chair.
Go ahead.
Okay. Secondly, I was thinking that with respect to just over the past several years, how revenues have been on the incline and going up, that maybe this could be a time when we could, stop the assessment and just pay for this stuff out of our general funds. But there could be some philosophical differences there, but I do feel as if, we're at a point now where, revenues are looking good on a recurring basis, and we can just go ahead and pay for it and have TennCare with this mission without this assessment. You have any input on that or any conversation you'd like to have about that philosophy?
Sure. Of course, I wasn't here back in 2010, so I can't speak to the discussions that happened at the time. I can say that you all have made substantial investments in hospitals over the last couple of years, over $1 billion. And a big portion of that, admittedly, is from the enhanced federal matching dollars that are tied to the assessment. But I think it's really important to note that many states took those dollars and used them to address general budget needs. And we didn't do that in Tennessee. You all did not do that. You left those dollars with the hospitals. And I think they are very appreciative of that, and we are very appreciative of that. But it's over $1 billion. We mentioned the 110 that you all appropriated last year. So I don't want it to get lost that together and through your appropriations, we've made substantial investments in hospitals.
Okay, thank you, Madam Chairman, and thank you, Mr. Commissioner. I appreciate candor in your answers. I really do. Thanks.
Representative Gant.
Thank you, Madam Chair. And I came in late, so you may have already talked about this, and forgive me if you did, but community mental health centers are reporting they have not received the FY24 provider rate increases payments from budget passed last year, and that TennCare is reporting the retro payments for those appropriations will not get processed or paid by the MCO until June or maybe July. Most of the community mental health centers have a June 30th year-end reporting. This is going to create a real significant challenge to post these payments, close out their books, and the mandatory independent audit completed and filed timely with the comptroller's office, as you know. Can anything be done to expedite this process and help these community health centers to get paid quicker?
Yeah, appreciate the question. We are working as fast as we can. Unfortunately, the main driver of those delays is the fact that we have to get CMS approval, and CMS unfortunately does not operate under our timeline. They operate under their own timeline. I don't know, Zane or Victor may have more detail to kind of talk to you about what it is that we are doing, and maybe some of the specific reasons for why it's taking so long. But I can say that the main driver of that is CMS at the federal level. But
Yeah, so for all of these sort of directed investments that we do, like this one that was put in the budget and passed by the General Assembly last year, to Director Smith's point, we have to get CMS permission. Now, CMS will tell us that that's a 90-day timetable. They do not hold to that at all. We submitted that as soon as we can, and then it takes months and months and months for them to get back with us, even if we continually follow up with them. We actually just got approval on the particular payment you're referencing about maybe a week and a half or 2 weeks ago. We did, after we got that approval, we told the industry, hey, great news, we finally got approval. So we're now working through all the logistical steps to operationalize all of that. But unfortunately, with the way things are working up in Washington right now, this is not an exception. This has happened on several other payment investments we've had to do over the past 2 to 3 years, where CMS will just take 7, 8, 9 months to approve something that they say they do in less than 90 days.
the other thing that plays into that is once we get the approval, you're talking about multiple contracts, multiple providers, multiple MCOs. So they have to go in, they have to adjust all of the contracts. They have to adjust their system so that the payments are correct. And unfortunately, the MCOs can't do that until they get the approval, because if by some chance CMS does not approve, then they'd have to go back and do it all over again. So it's just, I understand the frustration from the CMHCs. I would be frustrated as well. We are frustrated. We're working as fast as we can. Victor, do you want to add anything, or does that cover it?
Great explanation. Thank you very much. Thank you, Madam Chair.
Representative Shaw.
Thank you, Madam Chair. Thank y'all for being here. And I certainly thank you for what you do. I see TennCare helping people even when we're not satisfied with how much help you're giving. So thank you for what you do. Back to the hospital assessments, and I'll be brief. Did I hear you say, what is 63% or 60%? What did you tell me it was?
Oh, the hospital assessment, the maximum amount that's permitted is 6%. 6%.
6%.
Yes.
Okay. But I often hear the complaint about the hospital assessment. What is going on wrong with the assessments based upon what you all do and what they get? If that's, I hope I'm asking you a fair question.
Well, I don't want to speak for the hospitals. I would, I don't think anything is wrong with the assessment. I think what the hospitals would contend is that, and they can speak about this much better than I can. I think what they would contend is that they bought back these cuts in 2010 when the state was in different financial conditions than it is today. And that they had an expectation that at some point the state would buy back those cuts. And so understandably, they would like the state to buy back those cuts so that they could use those dollars to make additional investments. But it's also not unusual for a state to have a hospital assessment.
Okay.
Representative Shaw.
So how often do you all increase the assessments? Do you have an ongoing plan that you increase every year or every 5 years? How does that work?
It's really driven by the hospitals because they are the ones that are putting in the money. And so when they seek to increase the assessment, we have discussions with them because we are ultimately the agency that has to submit the request to CMS at the federal level.
Chairman Faison.
Thank you, Madam Chair Lady. Good afternoon, TennCare. Good to see you. Quick question. When it comes, kind of piggyback on what I heard earlier, when it comes to the recertification, I have some constituents who are on disability, Social Security. They got a small raise. Hey, Chairman Sparks, can you lean over just a little bit, one way or the other? I can't see the director. There you go. Thank you, Sarah. Thank you. They got a very small. One of my friends, he got $100 a month raise for cost of living. That in turn made him lose his TennCare. That's happened, I think, to several people who are kind of on a fixed income, and that small raise kicked them out. What is TennCare doing about that? And is it something that the state can do to fix that, or is that a federal issue that put them out of? We're talking a small amount of money, put them out of the ability to have Medicaid.
Yeah, a couple of things there. So you have one agency at the federal level that makes the adjustments on the Social Security benefit. And then a couple of months down the road, you have HHS, which makes the adjustment on the federal poverty guidelines. And they're both supposed to be based on inflation. And so ideally, you'd have a situation where the federal poverty guidelines go up in relation to the Social Security benefit. That doesn't always happen. In some years, one may be higher than the other. One thing that we do at the state level is we don't make any decisions to the negative until the poverty adjustments are made. So, but it is possible that even after the poverty adjustments are made, that I think it'd be very, very few, but it is possible that the Social Security benefit would go up higher. That happened in 23. This most recent year, though, it's the reverse. The poverty is going up higher than the Social Security benefit. So it is a challenge. But regardless of where you set it, there's going to be a cutoff. I think we do as much as we can by waiting until the poverty guidelines are adjusted. I don't know what more we could do beyond that.
Chairman Faison.
Thank you, Chair Lady. So follow-up question on the Tennesseans who had to recertify. They get a letter from y'all letting them know that their coverage is elapsed. When you represent rural areas that they're kind of already scared of government, they get a call, they call the phone number you tell them to call, and it's not the easiest to find somebody. What is y'all's plan moving forward for when you send a letter to somebody that they're about to lose coverage, that they get a live person that they can talk to and get it sorted out quickly, because that doesn't feel like what's happening in my district.
Yeah. Well, I can say, and I may have Kim jump in here. We've had more communication during this renewal process than we've ever had, and I think we've learned a lot from it. And I think we're going to take some of those tools and use those going forward. Also, going forward, we're going to, I think every state is experiencing this now because you have so many people going through the process that it's taking longer to connect with someone. That won't be the case going forward. I also feel like we make every effort to give individuals that are going through this process every chance to stay on the program. And I think in your slide deck, you've got kind of a diagram that kind of shows all the different steps and how it really is designed to keep someone on if they are eligible and if they want to stay on. But Kim, do you want to speak more to that?
Sure. Kim Hagan, Director of Member Services for TennCare. I think Stephen's right. This past year, we've seen unprecedented volume because of all the folks going through renewal for this first time after the public health emergency. And so, beginning with the people going through in April of this year, we should be back to a more manageable level. Some of the outreach he's talking about is every time we send a renewal packet, we also send a text and an email, and then we're doing calling, and our managed care organizations are also doing that. So we're reaching out, in every possible way.
We also have a contract with the Tennessee Rural Healthcare Association during this process, which I think has been very helpful.
I have no further questions on my list. So, Director, thank you and your team for being here today. Thank you for the work that's been done on TennCare. It's a huge part of the state budget. It's incredibly important to Tennessee citizens, and we appreciate the work that goes into it. It's never going to be perfect, but I think we have an obligation. I know your department works for that, and we have an obligation, I think, as representatives of our citizens to continue to try and make it better. So thank you for your work in that regard, and we appreciate your being here today.
Thank you very much.
Next up, we have the Department of Health. Dr. Alvarado, welcome to our committee. Thank you for being here this afternoon, and I know you've been patiently waiting for a few minutes. So we will ask you to just dive directly into your presentation, and then we'll have an opportunity for our members to ask any questions that come up as a result of that.
Thank you, Madam Chair. Hopefully the microphone is on. You can hear me okay? It's a pleasure to be with you today. I want to introduce my team very quickly. I've got, I would argue, one of the, if not the best staff really within state government. I've got Dr. Toby Abinson, Deputy Commissioner, Chief Medical Officer Dr. Tim Jones, Deputy Commissioner John Webb, and other members of my staff here behind me. I've been here a little bit over a year, had a chance to visit every county within the state. So I've been in all your districts. Beautiful state. Everybody's been very welcoming, and it's great to be with you here today. So we'll start and dive right into the budget discussions. We're going to go through our cost increases first. I think we'll just go down the list here on the first cost increase. This is year 3 of 5 of the Smile Tennessee pilot project. This is $18.1 million in non-recurring state funds. This proposal requests it's the 3rd year of scheduled funding that we have on this project. And this request directs $12.8 million to higher education institutions to provide continued support of expanded dental classes and the creation of remote clinics to improve rural outreach. In addition, $5.3 million in funds to support prosthodontic programs, dental programs for seniors, recruitment incentives, and clinical expansions. I'll talk a little bit more about the success we've had in this program later in the presentation. Cost increase number 2 is the Educational Dental Safety Net Care Pilot. This is year 3 of 3 of that, $3.375 million in non-recurring state funds. In conjunction with the Healthy Smiles Initiative, this funding continues the department's partnership with Lincoln Memorial University to expand access to dental care in underserved areas in East Tennessee. Specifically, LMU utilizes this funding to expand dental class sizes and create education sites to offer comprehensive dental care for underserved patients in 33 counties in East Tennessee. Item number 3 is a Rural Healthcare Resiliency Program. This is $50 million in non-recurring funds. This comes from TennCare Shared Savings. The Rural Healthcare Resiliency Program will target improvements in healthcare facilities and the delivery of healthcare services in rural and underserved areas. Through a competitive process, this program will provide grants to organizations and direct care providers to expand facility capacity and implement innovations to the delivery of integrated, higher quality, comprehensive prevention healthcare services. Currently, the department manages a similar ARPA-funded program of $250 million. I'll talk about that a little bit later on as well. And during that competitive grant process, the department received over $400 million in applications, showing a significant demand statewide. The proposed $50 million in funding would allow the department to offer a funding opportunity for organizations that did not participate in the federally funded program. Now, as you know, rural Tennesseans experience significant challenges in accessing resources to support behavioral and physical health needs. These challenges include the lack of adequate health care facilities in rural areas and shortages of qualified healthcare providers. Often, rural communities experience distinct social and environmental obstacles, including mental health challenges, obesity, and substance misuse. In 2022, Governor Lee convened the Rural Health Care Task Force to provide insight on the best ways to address the unique health challenges in rural communities. Comprised of 34 individual stakeholders, the task force included members from public and private organizations, state agencies, and the General Assembly. And the task force worked to develop practical recommendations for high-impact investments to improve rural communities' access to preventive and comprehensive healthcare services, promote equitable, efficient, and effective healthcare delivery, and improve health outcomes for rural Tennesseans. Cost increases numbers 4, 5, 6, 7, and 8 are based on the recommendations of the task force to improve access to care and the development of a workforce serving the health-related needs of rural Tennesseans. In fact, the task force also recommended item number 1. I want to remind the committee also that all of those in 4, 5, 6, 7, and 8 are going to be TennCare Shared Savings as the source, and they're all non-recurring funds. So item number 4 is for Center of Excellence. This is $1 million in non-recurring funds. Generally, access to care in rural communities is a significant challenge. There's great variability in the specific challenges individual communities face to offer core health services to citizens. And over the past few years, there have been several innovative care delivery models developed to help bridge the gaps in services in these communities. However, rural communities and service providers often lack the resources needed to evaluate and implement these innovative service delivery models. Recognizing these challenges, the task force recommended, through a public-private partnership, the establishment of a Center of Excellence. This COE, I'll call it for short, would provide an array of technical support services to rural areas to tailor healthcare access solutions that address the specific challenges faced by local communities. Item number 5 is the Center of Excellence grants. This is at $1.4 million. And as the COE works with rural communities, there'll be instances where overcoming some healthcare access challenges may require additional planning and support beyond the in-house capabilities of the COE, and additional funding to support local transition efforts. To supplement the COE's efforts, the task force recommended $1.4 million dedicated to the establishment of 2 grant programs for planning and implementation related to COE recommendations to local communities. Item number 6 is $5.4 million for the rural healthcare training programs. A key component on improving access to healthcare services in rural areas is improving the pipeline of providers supporting underserved communities. And studies indicate that rural rotation exposure in training or residency is positively associated with choosing rural practice. However, barriers include the lack of medical education programs and minimal training opportunities in facilities in rural areas. To assist in overcoming these barriers, the task force recommended the establishment of additional training opportunities, including funding for preceptorships, rotations, fellowships, and training tracks, and residencies in rural areas. Preceptors provide students with vital clinical education, which trains the next generation of healthcare professionals, and programs such as rotations, fellowships, and residencies can increase trainees' exposure to rural lifestyle and medical practice to improve in-state retention rates for providers. Item number 7 is rural specialty care. This is $1.1 million, again, in TennCare Shared Savings, and to improve specialist access in rural areas. The task force recommended $800,000 to create an e-consult platform for primary providers in rural locations to consult with specialists to improve the delivery of patient care. The e-consult platform will include real-time, one-on-one e-consults between rural primary care providers and specialists to seek clinical guidance and expertise to improve access to specialty care in geographically isolated communities and avoid unessential referrals. Additionally, the task force recommended the implementation of a specialist incentive pilot for TDH's Project Access program, which leverages nonprofit entities across the state to coordinate with local Tennessee Medical Association chapters and connect uninsured patients with healthcare services. Specifically, the task force recommended allocating $250,000 to incentivize additional high-speed specialty providers to deliver in-person services in rural communities. Item number 8 is a rural telemedicine program. This is for a little bit under $67,000 in non-recurring funds. This funding request supports the implementation of a one-year pilot designed to expand telemedicine offerings in rural areas. The pilot would be conducted in 6 sites comprised of 3 safety net clinics and 3 community-based sites, for example, like a library or something like that, to improve access to telemedicine and healthcare services in rural communities. Cost increase number 9 is for our laboratory courier expenses. This is $500,000 in recurring expenses. The state lab is subject to continuous review and accreditation by federal agencies, and these reviews ensure that the state lab is meeting both federal and industry guidelines. The most recent CLIA, or Clinical Laboratory Improvements Amendments Survey, indicated deficiencies in temperature monitoring of samples during transport. This is a finding for which the state lab has implemented a short-term solution. But the department's intent is to use this recurring funding to upgrade these courier services to ensure temperature control as the long-term resolution to the issue. And then cost increase number 10 is for Board of Pharmacy positions. This proposal establishes 2 part-time positions for the Tennessee Pharmacy Board as intended by Public Chapter 457 of 2023. No additional funds are needed as the part-time positions will be supported by existing dedicated funding. The next 2 things we thought we'd cover would be our reductions. Reduction number 1 is for the Federal Overdose Response Coordination Office. This reduction amount is in $2.1 million, 7 full-time positions. Effective September the 1st of 2023, the federal government reduced direct funding to the Overdose Response Coordination Office program. This funding supported grants to local governments and organizations for services to reduce incidents of opioid overdoses through community-based programs targeting high-risk populations. As a result of these federal changes, the department has reduced contracts and absorbed personnel costs to meet the current federal funding levels. Although the federal government reduced direct funding to the ORCO program, direct funding to local governments and other organizations increased. The department doesn't really know if these increases offset the total loss of direct funding to the department. And the second reduction you see there is for mainframe billing reduction. This is for $173,000 dedicated state funds. The reduction represents the net savings to the health-related boards due to the transition of board applications from the mainframe computer to other modern platforms. I thought we'd talk about some highlights within the department. I know it's often difficult sometimes to hear about some of the good work that we're doing, but the first slide we have here is on the healthcare safety net. A key tenet of this administration has been to expand and improve access to healthcare for rural and underserved populations in Tennessee. And in 2019, the Healthcare Safety Net program received $8.4 million in recurring state dollars. Since that time, the administration and the General Assembly have increased recurring state funding for the program to $31.1 million. This nearly 400% increase in funding is a direct investment in improving the lives of some of the most vulnerable Tennesseans. This investment in state funding expanded primary care and dental service offerings to 118 providers to uninsured Tennesseans through over 340,000 patient encounters. The volume of patient encounters is important. However, the investment in the safety net is more than improving access to care. It's also about improving the care that individuals receive through the safety net program. And in 2019, Project Access provided only care coordination services. After increased investment, Project Access now provides additional specialty care services through a network of volunteer physicians, hospitals, and clinics in 86 counties. In 2019, dental safety net providers only provided cleanings and extraction services. Through the increased investments, providers now offer restorative services, fillings, and diagnostics. And not only has the General Assembly's investment increased the patient volume of the safety net dental clinics, but it's also improved the services and support offered through these providers. Reimbursement rates for primary care patients have increased from $20 per visit in 2019 to $68 per visit in 2023, and dental rates have improved from $20 per visit in 2019 to $102 per visit in 2023. Also, in the last few years, the department has utilized safety net funding to implement a quality improvement incentive program for safety net providers. The goal is to improve clinical efficiencies and patient health outcomes. The Safety Net Quality Improvement Incentive Program is designed to improve the service provision and increase access for uninsured adults seeking care in the safety net clinics. Participating in the program results in a $20 per encounter bonus to the providers as well. The next slide we've got here is on Healthy Smiles Initiative. In 2021, Tennessee ranked 45th in the nation for the ratio of population to dentists. Nationally, there are approximately 60 dentists per 100,000 population, compared with 46 dentists per 100,000 in Tennessee. Estimates indicated that the state would need over 700 additional dentists to meet the current practice standards. Over 2.3 million Tennesseans live in a dental health professional shortage area. In fiscal years 2023 and 2024, nearly $28 million has been allocated to reduce barriers to dental care. We've dedicated $17.7 million to the expansion of dental class sizes at UT and at Meharry. Sets aside also $8 million to support expanded services, including prosthodontic services and dental services for senior citizens. And approximately $2 million is dedicated to provider recruitment incentives. Just to give you an idea, about in 18 months of activity, Meharry expanded their class size by 13 from 62 to 75 dental students. UT expanded their class size by 20 from 100 to 120. UT also expanded dental hygiene classes from 30 to 48. Educational capacity has increased by 16 faculty members between both schools. Meharry has 4, UT has 12. Both schools have started working on rotations at the Department of Health and other clinic sites. Meharry is covering Montgomery County and also has plans to expand to Smith, Putnam, Grundy, and Wilson counties. UT currently provides services in several clinics in Davidson, Knox, Shelby, Madison, Hamilton, Sullivan, and Cumberland counties. And both schools look to expand rotation in clinical sites in underserved and rural areas. I think they're looking at Kingsport also in the future. Grant funding assisted patients receiving nearly 1,000 procedures in the prosthodontic program. Smile 65 Plus projects served 3,481 senior citizens through 13,835 direct encounters, and nearly 1,000 patients have received case management and navigation services to assist in scheduling appointments and receiving services. And loan repayment program was also launched in February to improve retention rates for dentists in Tennessee. And actually we've also recruited several dentists already through that program here in the last year. And then our final slide we thought we'd talk about is our ARPA funding overview. A lot of good work that's been done here, but we've had the healthcare staff assistance of $120 million. This program provided funding to healthcare facilities to assist in offsetting increased staffing costs as a result of the COVID-19 pandemic. The ARPA proposal sets aside funding for hospital staff assistance of $70 million and nursing home staffing assistance of $50 million. We also had some previous funds for hospitals through the Corona Relief Fund. Hospital assistance portion of this project completed with an estimated total cost of approximately $65 million. And the nursing home portion of this project is still in process. The department is in the process of approving submitted reimbursements, dispersed a little over $15.5 million to date. We also have our new state public health lab of $200 million. This project replaces the current state lab located at the RS Gas Complex. The department has partnered with the Department of General Services to construct the new laboratory. So DGS has taken the lead in shepherding this project through the capital process. DGS has been an excellent partner for us, engaging our staff through the design process to ensure that we receive maximum functionality for the investment. And the project is on schedule and projects to be within budget. That's a rare thing I think we hear within state government, that is on schedule and projects to be within budget. Next, we've got also our local health department infrastructure, which is $129 million. This project is comprised of 2 major components. The first is the establishment of a grant program to local governments to build, renovate, and upgrade local health department facilities statewide. These grants are available to the 89 rural counties with the minimum project amount available of $450,000. The grant program required a local match of the lesser between 25% of the total project or 10% of the local government's ARPA direct allocation. 78 counties participated, with 76 having executed contracts at this point. And the second component of these funds is dedicated to the construction of 1 new regional health office located in the South Central region. Funding for this portion of the project is set at $17.5 million. We're also working with DGS in getting that done. $30 million was also being put aside for regional forensic centers. The department's providing grants to support both Knox County and Hamilton County governments for the construction of 2 new regional forensic centers. Contracts obligating funds to the counties have been executed, and the department is confident that full spending will occur for these projects within the ARPA timelines. And then we also had $250 million in healthcare resiliency program. These are ARPA funds. This program looks to expand physical hospital capacity and enhance care delivery at healthcare facilities statewide. This is the one that I mentioned. We had $400 million in requests. The program has a capital section where healthcare facilities will competitively apply for grants to expand physical capacity. And there's also a matching component required for consideration for the grants, 50-50. The second part of this program deals with the healthcare practice transformation. Although this program does not require a match, these funds will be dispersed in a similar manner as the capital grants program in a competitive process. And between both sets of funding, the department has allocated funds to support 93 projects statewide, 33 for capital investments, and 60 for practice transformation. Madam Chair, that's my presentation. I try to go as quick as I can. I know we're allocated 5 minutes, as I say, so I have a God-given ability to talk fast. But with that, we're open to any questions.
You certainly do have the ability to talk fast. I can tell that you're not homegrown Tennessean. Nobody in Tennessee other than Leader Lambert can talk that fast. I have a list of people with questions, beginning with Chairman Hawk.
Thank you, Madam Chair. Commissioner Alvarado, thank you for the presentation, the wealth of information that we're all trying to digest at this moment. So thank you so much for that. I want to talk about the slides that you showed, both the cost of the dental service pilot program as well as some of the solutions and where we're trying to get. And I will brag on our region of Northeast Tennessee, the project that Kingsport and Ballard and the University of Tennessee Health Sciences Center and ETSU are coming together to provide the potential for dental training and dental school in Northeast Tennessee. So that means a lot, and it's a partnership that is quite unique that we are looking forward. And this fits right in line with that. You mentioned in your presentation, total of $28 million of non-recurring funds has been provided so far for the first two phases of the dental services pilot. Have we spent all of those dollars? I'm gonna go ahead and get everything out here, Commissioner, if I could. Sure. 3 questions here. Have we spent all of these dollars? And the components of the pilot program in dental services, supporting our schools, increasing services to individuals, recruiting dentists to practice in rural Tennessee. How are we doing in each of those phases in the early stages of that? And results. What are we seeing as we're being asked to fund $18 million going into phase 3? So just broadly those questions. Thank you, Madam Chair.
Sure, and thank you, Representative, for that. So as I mentioned, I think we've got $28 million have been allocated to reduce those barriers. We dedicated $17.7 million of that to the expansion of dental classes for UT and Meharry. Of that money, $8 million was to support expanded services, including prosthodontics, so denture services, also for senior citizens. We've had quite a bit of luck with that. And $2 million is dedicated to provider recruitment incentives, so basically to get more dentists to come in the state. I think we recently got a report this morning that I think had 14 vacancies, down to 11 at this point now. So we've recruited more dentists in, which has been really good news. And like I mentioned, a lot of the class sizes have already been increased within both of those schools. We've recruited more faculty and staff. We've had sometimes some difficulty in trying to recruit some of those folks in, but we've had meetings regularly with our with kind of the committee that's come together to oversee a lot of this, to make sure that we're doing what we need to be doing and recruiting people in. But we've had, if I go through details again, the Smile 65, 3,481 senior citizens, had 13,835 direct encounters. So that money's going towards that. We've had 1,000 procedures in prosthodontics, which are dentures. Nearly 1,000 patients have gotten case management navigation services to assist in scheduling appointments and receiving services. So that's all been really good news. I don't know if we can have, John might be able to give us a little more detail on specifics as far as amounts of what's spent and unspent.
Sure, Chairman Hawk. We carried forward about $4.5 or $4.6 million from year one into the current year. That was largely due to some delays in ramping up such a large project. Part of that was the loan repayment program, and then getting, academic partners to spend the full amount, because it's a new piece. But the good news is that we're on pace to spend. We're spending at a much faster rate than we were in the previous year, and the loan repayment program launched in February, and so we anticipate a big uptake on that as we go forward.
Chairman Hicks of Hawkins.
Thank you, Chair Lady. Commissioner, good to see you and your staff here. My question is going to revolve around the Rural Health Care Resiliency Program, if I can spit that out. The second slide that you showed, item 3 there, it shows the $50 million. I think you said that was going to be non-recurring. So the question that I have revolving that would be, how long do you think it'll take for your department to actually implement the grant program? And then also speak, what is the plan for the distribution? Sounds like you've only got a few minutes to answer that, so you better hurry. Will there be a required local match? And then how many grants do you see? I know that's a bunch, but.
So the beauty of this is it's wide open. We've had, I've mentioned that the ARPA program that we had with $250 million, obviously with federal monies, there's always strings and programmatic strings attached to some of that. We went through a very detailed process, took applications, and that was statewide. And we scored those based on multiple factors for that money. But this will come directly from state funds. So it keeps it wide open as far as how we went. Obviously, it's more for rural healthcare. So I think we're going to have a focus, obviously, for rural counties where those are needed. So we have, I think, a wide open option of how we can do that. That can either be done through another process of taking applications. We can use the existing applications we already have had. There is about $150 million of requests that we could not implement. So we could take those, identify areas of need in rural communities, and just continue down the list of what we already had. So it's a wide open. I don't think we have any rules set around that. I think if this gets approved, we'll have an opportunity to establish a new program and make all those determinations again. And we have a model of something that's been successful so far that I think has been well received with the ARPA funds. We could do something similar to that, but with state funds, it'll be a lot easier to get that money out.
So is there a way to, as far as for the applications in these rural communities, how do you make sure that those communities that with the most need actually get the grant? So is that what, will you look at that, like who has the biggest need? And then kind of to piggyback off of that, how do you make sure that those rural communities who don't really have the resources to be able to make sure that they get their application in correctly and accurately? Is there a way the department is helping with the rural communities to make sure that all this is filled out correctly? And
Sure. And I'll probably let John, I'll probably let him piggyback on this a little bit. I think with when we had our ARPA funds going out, obviously there's always concern. I would argue, and we've talked about this, and I think Deputy Commissioner Webb has talked about it, probably the most audited program that will be in American history potentially. We want to make sure that our applicants do things the right way. We don't want to have anything go haywire later on and have them claw back money from people that have gone out and done things in good faith. So when we did the ARPA funds, we had a third party come in. We set down kind of a formula of the things we were going to grade them on, and the third party graded all those programs and gave them a score. We went down the list based on merit on those. We've also used that third party to assist in applications to make sure that if they have any problems or concerns, we can answer those questions and assist in that process. Again, federal dollars can be a lot more complicated just to make sure. Through state dollars, it's a lot easier, I think, typically. And so we can make a scoring package. It's up to, we can make that determination of how we want to do it. If we want to have it be based on economic need, based on areas of more importance or whatever, or it can just be done based on merit, but in rural areas. John, I don't know if you want to add on anything to that. Yeah.
Okay. All right. Thank you very much. Thank you, Commissioner. Thank you, Chair Lady.
Chairman Hicks of Washington.
Thank you, Madam Chair, and thank you for being here, Commissioner. We really appreciate it. And you mentioned that you was very good at talking fast. But one of the good things that I like about you is you're a very good listener. So thank you coming to our county and listening to us. I really appreciate that.
Thank you.
In the governor's proposed budget, which includes 6 cost increases totaling about $59 million that are funded with non-reoccurring TennCare shared savings. The questions are, will this funding be used to build up ongoing programs that will then be left to seek funding elsewhere when the non-recurring funding ends? And when the TennCare shared saving runs out, is there a plan for continuing any of this funding? That's the 2 questions.
Those are difficult questions, Chairman. I appreciate those. I can go by these one-on-one and see the Center of Excellence. If there's a rural healthcare task force report. I know sometimes it can be, for myself, it's something that's near and dear to my heart, so we read it in detail, but they give a lot of recommendations on a Center of Excellence, how it can be established, and they give some recommendations on how to do that. Part of what they recommend is that you can get it established is that some of these are seed money. So some of the item number 5, for example, which are the grants, they're hoping to get those started, hoping you might be able to have other parties be able to raise money for a Center of Excellence to provide grants and do some of those things. And then also take a look at a Center of Excellence. You're hoping there might be other opportunities for other methods of funding that. Obviously, it would be tremendous if you can get recurring funds for this in the future. But to get this started, I think sometimes you need that to get things off the ground. And then there's an opportunity also to use outside entities to raise funds for that as part of the hope, at least part of the recommendations they had. On some of the things like the training programs, obviously some of these are clinical positions to help with residency positions. Those are things that are of tremendous importance. If we can have more residents, I'm a case in point. I'm someone who grew up in California, came to Kentucky for residency and wound up staying within an 80-mile radius of that area and practiced medicine for 28 years. I think you'll find that if you can get somebody to do their residency program in a rural area, the odds are they're going to stick around. But some of these things, again, are just hopes of starting programs up and hoping you might have other partners, either private partners, to be able to assist in funding that. And a lot of the things like specialty care, some of these things are a one-time investment, a rural telemedicine program. You just need sometimes, again, some seed money to get an e-consult program or a platform set up to allow those things to occur and take place. But I mean, obviously, it's always ideal to get recurring funds for things, but I think it's a lot of the task force recommendations were to get these things started and then to hopefully have other funds come in, perhaps even from private sources. John, anything you want to add?
Sure. Yes, sir. Just building off that, the Rural Health Task Force had like a 5-year plan on how to fund this ongoing. So I would imagine that's kind of the roadmap as far as funding. You know, we can't predict the future of what this might be, but as Commissioner pointed out, a lot of this would be the hope would be to have public-private partnerships going forward and raise private funds. One thing I would note that 50 million of the 59 million is related to the health resiliency program, and that's probably like a one-time block of money. And so we probably wouldn't look at that as a recurring amount initially, at least.
Thank you.
Thank you both. Just to go back to an earlier question, you mentioned the third party oversight or assistance in helping to determine priorities and provide an objective source for allocating these funds. In another department that shall not be named until they get here, I'm hearing a lot of concerns that the third party they have hired has been an obstacle versus, facilitators. So I'm just interested, do you feel that your funding is getting out the door in a timely manner using this third party vendor?
John, you might be able to, I mean, I think we've heard concerns that we've gone back to that third party and told them, you need to make this as easy as possible for the folks that are out there, particularly in things like helping with applications and being able to do a lot of those things. So as we've heard complaints, we've taken it straight to them. We've often accompanied them to visit with a lot of our local folks if they've needed help and assistance with those things. So aside from that, I mean, a lot of the concerns and the angst has been mostly with federal regulations and requirements, because a lot of our partners, when we have dealt with them with grants, it's pretty simple with state grant and dollars, with state dollars. When federal dollars are involved, it's just a much lengthier application. And a lot of them almost want to toss up their hands and just say, I give up. And so we're trying not to, because it's one-time funds. There's a deadline as when those things have to be allocated and spent. And so we're trying to encourage them to use this, because they're not going to get this kind of investment in the future when it comes to federal amounts. I think if it's state dollars we're worried about in the future, I don't think you're going to have the same concerns as we do with the federal dollars that are there for applications. But I don't think we've heard particular complaints. If we have, we've typically gotten involved directly.
Thank you. I appreciate that involvement and trying to, just facilitate and get those dollars out the door. We are rapidly approaching the lifespan and the deadlines for those dollars not only to be allocated, but to be spent. So this is a once in a life opportunity for a lot of things in Tennessee, and I would not like us to squander that opportunity. Chair.
Thank you, Madam Chair. Commissioner, thank you to you and your team. And just quickly just a couple of comments. You answered most of my questions related to ARPA funds in your detailed presentation, but just quickly, because he's sitting to your left, I just want to thank you and your team and Holt in particular for all the work you did for us over the summer. Holt really went above and beyond in helping my constituency engage directly with two who are trying to get licensed to counsel, and has helped walk them through. And I mean, he really did go above and beyond. So I just wanted to recognize that. He did a really good job for us this summer.
Thank you.
And then just to the ARPA funds in particular, you went through it and I may have missed it. You did a good job detailing. Can you speak specifically to progress on the public health lab initiative? And then just also quickly go through the timeline again on expenditures, because I know you guys got around $730 million. And as of December of 2023, $88 million had been spent. So if you could just touch on those two things, please.
Sure. I'll just briefly again that we've got the new building is going to be a facilities revolving fund facility, right? So DGS is involved with us in that. They've been great for us. It's on schedule. It's going to be within budget. The early design phase presentation appeared before the State Building Commission in January. And then construction contracts for the project are expected to be awarded in late spring of 2024. So it's just around the corner. John, I'll let you provide more detail as far as numbers.
Sure. I think our obligation number, when you see the next report at the end of April, will be astronomically different than what's being reported now. Part of our expense problem, and the chair lady is correct. I mean, there are issues with getting money out due to the federal regulations that we've had, and we've played it very conservatively because we don't want to pay it back. But we anticipate having all the money obligated by the initial deadline of 2024, which we will have that done. And then the spending will show up a little bit later because a lot of what we're doing is capital related. You know, the state lab, a huge capital project, and we won't see those expenses until after the construction contracts. We've got the local health department infrastructure, which will be another capital project, or several capital projects. So I think we'll see those expenses later on. But we should be picking up speed as we progress through the year and into 2025.
Great. Thank you. Thank you, Madam Chair.
And again, to belabor a point, another concern is these are capital projects. And the other department that I alluded to, many of those are as well. And there are all sorts of delays that can happen with capital projects. And we're up against a hard deadline to have the monies expended too. So I'm just concerned that the longer it takes us to do this front end allocation, the shorter time we actually have to complete the project. And then we're left with a half-done project and can't draw down the funds and we're on the hook. So I just would encourage everyone to be as expeditious as they can about getting all of these dollars allocated, obligated, and then getting contracts up and running. And with that, I will get off my dead horse. Chairman Crawford.
Thank you, Madam Chair Lady. My question is dealing with the COVID relief funds. In the questionnaire that you provided us, it says the Department of Health has been awarded over $2.2 billion in federal COVID relief funds since 2020. The amount expended to date is less than half of that amount, some of which has already been returned to the federal government. My question is, have there been any barriers to spending the full amount of the federal funding? And how much do you expect to send back this September?
I'll let John answer that.
Good question. The problem has been volume. Be honest with you, Chairman Crawford, it's a lot of money. It's a lot more money than we ever anticipated getting. It's a lot more money than we ever anticipated spending. You referenced what we got total, and that's through, ARPA and then the direct COVID relief grants. The department got about $1.1 billion in direct COVID money, and that's from the CDC. We've spent about $670 million of that. There is no way we will approach $1.1 billion. And so I anticipate us returning money as these grants expire. Usually we'll get a 1 or maybe a 2-year federal extension, and we've been exercising those as they've become available to try to spend the money. But candidly, I'd say if we spent $800 million of that $1.1 billion, that would probably be pushing what's doable.
Representative Garrett.
Thank you, Madam Chairman. Thank you all for being here. Hopefully we can see the light at the end of the tunnel here and y'all can get out of here. So I've just got a few questions regarding the Tennessee Strong Families initiative. Last year, you all appropriated some money we appropriated some money to fund that particular program with 2 positions. And that program was supposed to expand the community health access and navigation in Tennessee, the CHANT program. So my questions revolve around that program. I believe just over $5.6 million recurring was budgeted for that program, with $1 million in non-recurring. So 3 questions for those that might know the answer to these. Have these positions have been filled? How many grants for the doula services have been given? And then finally, how many families have been provided with care coordination from this particular fund? So if you all could give me some information regarding the CHANT program, that would be great.
Yes, sir. Absolutely. I'll try to remember your questions. I may go a little bit out of order if that's all right. The doula pilot project, we have made 6 awards related to that. We had a competitive grant process that concluded in November or December. We've worked with the contracts so that the organizations would be, I guess, able to spend down that money. Hopefully by March 1, we start that. And so that would be the $1 million that was non-recurring. A portion, as you mentioned, was related to CHANT. A lot of what our folks have focused on are expanding pathways in terms of prenatal and postnatal care and safe sleep studies. Those are the kinds of things that they've been pushing. Last year, they assisted around 13,000 people in those similar tracks, and we expect at least 13,000, probably more, by the time we run the numbers at the end of the year. So all those things are moving very well. One thing that's a little bit different than what we've done in the past is that our CHANT program is working with our injury prevention and surveillance program to kind of create an infant mortality infant mortality strategic plan, which is something that's really new for the state. And so we're hoping to get some best practices involved with that and kind of have a map for us to pursue funding in the future. And so that's kind of where we are with the program. And I don't know if Dr. Amundson has anything to add to that or not.
Well, the only follow-up, I think there was also creating 2 positions.
Oh, yeah,
Were those,
sorry about
those,
that.
I would assume those have they been filled or?
One of two has been filled, and I think the one that we filled was an epidemiologist, and then we're working on the second position right now.
Okay, good deal. Thank you very much for that update. I really appreciate it. Thank you, Madam Chair.
Chairman Baum.
Thank you, Madam Chair. Commissioner, I've got a question about the Healthcare Safety Net program. Last year, we allocated a couple $1 million to improve health outcomes by developing some objective measures. And I guess I was just wondering if you have any update on that for us on what the objective measures might be or whether we've got those improvements in place.
Chairman Bond, we've implemented that as a part of an quality incentive payment program. We've got 50 clinics that are participating now. We look to expand upon that. That's probably, I don't know, half or a little less than half of what we have as primary care clinics. So we've had really good participation. Part of the measurable outcomes really depends on the clinic, right? We're looking at patient health outcomes and probably what project they decide to do and how that would impact service delivery at that particular clinic. So if, for example, if somebody wanted to improve clinic flow and they decided to adopt an IT system that helped them do that, then we would probably be able to measure them based on how many people they see in that kind of thing. So it varies by provider, but we're pretty excited about having 50 people on board or 50 clinics on board at this time.
Okay. And we've got it, so it's essentially implemented.
It's going and we're looking to expand. Yeah. So we're not done yet, but we're well on our way.
Okay, thank you.
Representative Freeman.
Thank you, Madam Chair. A lot of questions here. So in last year's budget, we shifted several $1 million in HIV surveillance and prevention from federal dollars to state dollars. Does this proposed budget include the same total amount of funding from last year?
Yes, it's in the recurring. It's a recurring amount and so it's in the budget for this year. Yes.
Has there been an increase for additional need or inflationary costs to provide those services?
I'm not sure about increased inflationary costs. I know we've had quite a bit of success, and we've had an update from our program directors on this. We've exceeded the amount of prep tests or prep that's been put out there. We've had a doubling of the tests that have been done, some mobile kind of SSP programs and things that this has helped fund. So I think everyone's been very pleased. It was a tremendous investment really to help a lot more screenings and have a lot more people tested for it. So we've been encouraged by that, but I'm not sure as far as inflationary costs.
Representative Freeman, we did not have any inflationary cost included in the budget, but it's the same $9 million recurring as added last year.
Great, thank you. And then there are a number of direct appropriations to specific community organizations to provide, again, HIV surveillance and prevention services. Are those organizations all receiving the same amount in this year's budget?
Yes, they are.
That's all I have. Thank you very much.
Chairman Moon.
Thank you, Madam Chair Lady, and Commissioner, thank you for your tenacity in pursuing the ARPA funding. I had an unusual number of constituent issues come up in the last 6 months, and to echo what Chairman Zachary mentioned earlier, I found your staff to be extremely responsive, even when it went outside your agency and the problem was somewhere else. They stayed on that problem until it was resolved, and that's very refreshing. Thank you so much. Thank you, Madam Chair Lady.
Like I said, Representative, I have the best staff in state government. I'm convinced of it.
Representative Shaw.
Thank you, Madam Chair. Thank you, Doc, for being here. Thank you for your work. Thank you, staff. Do you all have a number of how many people, I want to go back and revisit this, passed away during the COVID time when COVID was rampant in Tennessee?
Total amount of
People
cases
that
and mortality?
died from it.
Dr. Jones, I don't know if we have that. Yeah, I don't know that we have that information. We can get that for you if you'd like to know. What is it, a particular time frame or just from the beginning of the
Well,
pandemic?
I guess I'm wondering, well, let me ask you this. Do you anticipate, because I hear from time to time that it might be coming back, do you anticipate it to come back again from the forecast that y'all get from healthcare officials? What's the thought about it?
About COVID in
Yeah.
particular. Yeah, I think, again, COVID is going to be, it's a coronavirus, which is, they've been around for a long time. This particular virus is brand new. So we're learning as we go. So I think everybody has to remember that we're very used to having a medical community that knows a lot about a lot of things, but we don't know everything. There's a lot of things that we don't know. And so when something new comes along, we learn through experience as we go. And so we can monitor waves of these infections come through and the amount of infections. We do a lot of that based off of our hospital admissions. We do a lot of wastewater testing and things to determine how much infection is out there. We've been able to monitor that, and we've seen that the severity of illness and the spikes of the amount of infections have been a lot less. And we've gone through a full winter cycle where we've seen those be a lot less than they were before. But it's still a virus that if someone catches can still be lethal. And so we remind people there's a lot of respiratory viruses right now that we're tracking: RSV, influenza, COVID. If a lot of folks contract those, they can be a lethal infection for babies, and for adults, both in those different types. So what the future will hold, it's very difficult for us to predict. We can look at the past to see if the severity seems to be declining. We still have, again, if for the last 4 years, I think, unless someone's been living in a cave, they know what opportunities they have. There's vaccines available. There's acute treatment available. We would encourage people to, take precautions. If they're ill, if you have a fever, stay at home. Wash your hands well, that sort of thing, to prevent infections from occurring. So we have all those things before us, and we encourage people to talk to their providers about what's best for them. But will there be a more lethal infection in the future, just as lethal? Hard for us to project. We do know what it is. We know we've got treatments and things available and preventative measures available that people can seek and use.
Representative Shaw, go ahead.
Thank you. So what would we do if we are returning this money that we got for COVID? Now, what would we do in the event of another emergency? Could we get the money, not the same money, but could we get money again? What would we do, I guess, is my question, since we returned so much. And I assume we had to if we didn't use it. I get that. But I think my concern is, what would we do with another epidemic if we had one?
Well, I think as far as funding, I think there's a deadline on that from the federal government, I believe, in terms of that had to be used by a certain period of time. So I don't know what the federal government's response would be. But again, we've got people have just like influenza back in 1918 when that hit. It was kind of an international pandemic. There was vaccines that have been developed from that over time, and we've been recommending those for over 100 years. We fortunately we've had some years where it's been more serious than others, and we've had higher fatality rates, and a lot of that just is based on the mutation of the virus from year to year. There's a lot of surveillance that goes on over those viruses. Often we'll look at what the Southern Hemisphere is doing because they have their winters and summers opposite of ours. So if they see a particular virus taking off in the Southern Hemisphere, that often will notify people in the Northern Hemisphere to be prepared for that virus to potentially spread. And we do a lot of that monitoring internationally, just to monitor what the cycle of those viruses are going to be. So we just remind people what we know so far, and we'll be learning more year to year. on what this virus will do. But if it tracks like previous viruses, then we base our recommendations like we've done for that over the years. And I'm sure that we'll learn many more things as we go. So I always remind everybody that it's something that we have to learn. Sometimes things that we see now, I use the example of heart failure and beta blockers. 25 years ago, if I gave you a beta blocker for heart failure, it was considered a malpractice. Today, if I don't give you the beta blocker, it's malpractice. Did heart failure change? No. Did beta blockers change? No. We've got 25 years of experience that we've learned to say, hey, here's the recommendations now. So the same will apply with this virus as with any infection. And so to know what the future is going to hold is going to be very difficult. But all we can do is, based on the experience we've had, is apply what we know, the treatments we have available, the preventions we have available, and recommend them to people, and they can make those decisions going forward. Yeah, sure. Yeah.
Representative Shaw, if I might just add one thing, I don't want to leave the committee with the impression we're not spending money just to not spend it. We're spending money in appropriate ways, and we're maximizing what we can do with that federal grant dollar. My comment earlier was really that there's been such a volume of money that it's hard to spend that amount of money given the timeframes that are set aside by the federal government.
Thank you, Madam Chair.
Yes. Thank
Representative Miller.
Thank you. You just answered that question because I'm sitting here based on your first answer. We got all of these federal dollars and we can't spend them based on volume, but you did say that maybe the federal government is in our way with the rules and regulations. How much is that a factor?
I can't, it probably varies grant to grant. We've got a lot of large grants. There's some things that we would probably like more flexibility on. I mean, that happened during the middle of the pandemic with the Coronavirus Relief Fund. A lot of the parameters were very narrow with what we could spend money on, but as the pandemic progressed, those parameters were widened and we were able to spend on more things. So, we're really not in a defensive mode as we were, when the pandemic first came out. We're now looking at building infrastructure, as we've kind of alluded to in the ARPA projects. These are all projects to help us deal with the next problem. Hopefully there won't be one, but we're building capacity in all these grants to the best of our abilities.
Representative Miller.
Thank you for that. You said that every so often you go back to the federal government, you look for extensions, 1 year, 2 years. Are you having the same conversations with federal government, giving you at least more wiggle room to expend these dollars? Are you having those often conversations with the federal government?
Sure. I think when we've had those conversations, it's been a big project type thing. We had wanted to do some IT upgrades at one point, and that was not allowable by the federal grant, and we lobbied very hard to do these upgrades. So there are times where we do that. I can't tell you how often we do it, but it happens on occasion.
Representative, also to that point, we have an organization called ASTHO, which is an association of health officers around the entire country. We meet typically, compare notes. They advocate for flexibility in this from the federal government routinely, just like NCSL would be for you all, for federalism to be allowed flexibility in using federal dollars. And so that's usually a typical conversation when we have opportunities to speak to the CDC or the members. The typical complaint is make it as easy as possible for us to use those funds. Yes.
Yeah. The other thing is we are by no means unique in this failure to spend money. I mean, every other state is having exactly the same problem. So I do think that the sort of lobbying or advocacy for opening up, letting go of some of the strings or opening up the flexibility is not only we fighting for it, but all other states with our association. So we're trying.
Well, Dr. Alvarado and your team, thank you for being here. A lot of interest, obviously, as you saw, in what you have to present to us, and a lot of interest on behalf of this body, and I know your department as well, to make sure that this opportunity that we have with this, just unprecedented amount of federal dollars, that we use them well, because these are taxpayer dollars, as someone mentioned earlier. It's not free money from the sky. We are all going to be on the hook for those dollars down the road. So we want to make sure that we use them wisely. We don't want to just spend money just to spend money. And I thank you all for monitoring that process. That does complete our hearings for today. As I have no further questioners on my list, without objection, we are back in session. And that completes our calendar for today. We
Thank
will
you, Madam Chair.
continue our budget hearings at 8 o'clock in the morning. See you then. We are adjourned. 8 o'clock.